What time is it? It's showtime. Our next case, a 60-year-old man with a headache, a dizziness, and blurred vision. By itself, headache, dizziness, blurred vision, and fatigue. That could be Waldenstrom's macroglobulinemia. That could be a leukostasis reaction. By itself, that's not going to be able to answer the question, what's the most likely diagnosis? This pruritus issue, we said, we're in the hematologic malignancy section, so pruritus for us means basophils releasing histamine. And the big issue about why all of a sudden saying we don't smoke, why it's saying it doesn't smoke is saying this is not a hypoxic person with COPD, and the spleen is big. Okay, ladies and gentlemen, hematology is a laboratory diagnosis. There's only 2 or 3 physical findings in all of hematology. It's not like cardiology where you can tell that somebody has, bradycardia, hypotension, distended neck veins, bradycardia, hypotension, distended neck veins, Canon waves, bradycardia, hypotension, Canon waves. Even before the EKG, I know it's 3rd degree or complete heart block. A diamond-shaped systolic murmur that gets worse with Valsalva. It's HSCM. There's nothing like that in hematology or nephrology. Hematology and nephrology are laboratory specialties. So it's only once you get the high hematocrit that you know that this is polycythemia vera. Because the high hematocrit and also, now all of a sudden the big spleen goes with polycythemia vera because the spleen is trying to suck up excess red cells. Also, not just the red cell count being elevated in polycythemia vera, but also the platelet count and the white cell count. Notice all three of them, it's like the opposite of pancytopenia. That's why it's polycythemia, because the opposite of pancytopenia, this is the only thing in the world where all 3 cell lines can be up. No medication and no other disease elevates all 3 cell lines. Next is, why is there dried blood in the nostrils? Because the sludging actually bursts the blood vessels and causes epistaxis, because they back up like a 1,000-car pileup on a highway. Also, this MCV is low. Normal MCV is 80 to 100. Why? Because you're using up all the iron. You see, in polycythemia vera, you're using up all the iron because you're making so many cells. You actually become microcytic. And by itself, there's only 3 things in the world of a microcytic erythrocytosis. Microcytic, small cells, erythrocytosis, extra red cells. One is hypoxia. That's why excluding hypoxia is mandatory for a diagnosis of polycythemia vera. Number 2 is thalassemia. Thalassemia gives an increased number of red cells, but you're anemic. You're not having increased hematocrit. So that makes this polycythemia. In history and physical, primary polycythemia, meaning it's not reactive to hypoxia. Not reactive to hypoxia. Hypoxia will not give you a big spleen. Because the big spleen is from the red cells being sucked up because it's a cancer. It's red cell cancer. So pallor and erythema by itself, no. But the big spleen means that this is a primary polycythemia, not secondary to hypoxia. Which tests are first? You have to exclude hypoxia. You have to be sure that it's not in response to erythropoietin. Now, erythropoietin can't increase the platelets, can't increase the white cells. Erythropoietin is not going to increase the platelets. It's not going to increase the white cells. But what if you just presented with just an elevated red cell count? Just an elevated hematocrit. Polycythemia vera can do that. It is a true polycythemia. Polycythemia vera, because the erythropoietin level is normal. What if you had a renal cell carcinoma presenting with increased red cell count? Because a small amount of renal cell carcinomas, kidney cancer, makes erythropoietin. What if this was the early days of renal failure and somebody was overdosing you with erythropoietin because you're getting too much at the dialysis center? So by definition, it is a high red cell count in the absence of a high erythropoietin. The same way Graves' disease is a high thyroid level, high T4, in the absence of a high TSH. In the same way, adrenal origin hypercortisolism is a high cortisol in the absence of a high ACTH. The most accurate test overall for polycythemia vera, BCR-ABL is for chronic myelogenous leukemia, JAK2 is in myeloproliferative diseases, myeloperoxidase is in acute myelogenous leukemia, smudge cells are an artifact of CLL. The most accurate test is the Janus kinase 2 mutation. Now, we used to do these old tests called increased red cell mass test, nuclear red cell mass test. If you see that on your test, it's always wrong. JAK2 for essential thrombocythemia, which is platelet cancer, and for polycythemia vera. Which medication can cause a picture like this? There's increased reds, increased white cells, increased platelets, increased reds, increased white cells, increased platelets. Which medication can do this? Testosterone makes red cells grow. Did you know that? Most people don't know that testosterone causes an erythrocytosis. Part of the reason that a professional athlete will abuse testosterone is not just because it makes the muscles grow, it's because it increases the red cell count, because what's the point of having big muscles if you can't supply oxygen to them? So there are testosterone receptors on blast-forming units for red cells. Really? Yeah, testosterone receptors in your bone marrow. That's the fact. Growth hormone can increase red cells as well, but erythropoietin can't make the platelets and can't make the white cells go up. All three of these can only make the red cells go up alone. The best initial therapy used to be phlebotomy. Now the best initial therapy is phlebotomy. We only use hydroxyurea if phlebotomy is not controlling it. Because what's the problem with using hydroxyurea? Well, hydroxyurea in long-term use can actually lead to malignancy, hematologic malignancy. The hydroxyurea is oncogenic itself. The same way lidocaine and amiodarone, antiarrhythmic medications, are proarrhythmic. They can cause arrhythmias. So, if it doesn't work, then you may use hydroxyurea. The most common cause of death is that what happens is that sometimes people clot and they thrombose off because of increased sludging with red cells, and that's understandable. I'm all clogged up. So a 73-year-old man with polycythemia vera who's been getting phlebotomized for a long time. And now all of a sudden, what's happening is his spleen is big, but he's got teardrop cells. Teardrop cells and nucleated red cells. When you see the word nucleated red cells are the developmental step just before the reticulocyte. So when you see nucleated red cells, this is like teen pregnancy. This is like a 16-year-old going out to war. Why are you going out of the bone marrow when you're not fully mature? You should at least be 18 years old as a reticulocyte. A nucleated red cell is an early precursor cell. It means that the marrow is under stress. It means that the marrow is under stress. Parvovirus does decrease the hematocrit, but parvovirus doesn't give nucleated cells and parvovirus doesn't give teardrops. Parvovirus just freezes the marrow. Myelofibrosis will cause both of these things. Hemolysis doesn't give you nucleated red cells, and hemolysis doesn't give you teardrops. So when you have a myelofibrosis, the red cells are squeezing out through the fibers of the bone marrow. Myelofibrosis, the red cells are squeezing out through the fibers of the marrow, and that's why they become teardrop shaped, because they're squeezing through into a point. The same way babies are born, and they have little pinhead tight-topped babies, where the baby's head's going through the vaginal canal, getting squished up to a point. The therapy for people who have myelofibrosis, you can't transplant it because it's fibrosis. IVIG is for infections and for ITP. Where's that? Okay, so what you do for people who have myelofibrosis, I just had a little, did I just have amaurosis fugax? Did you? Did you see a blank slide in the middle there? How'd that happen? Okay, so lenalidomide is the son of thalidomide, and lenalidomide, what it does is it actually stops the myelofibrosis. Myelofibrosis, and myelodysplasia. Thalidomide, lenalidomide. A patient with myelofibrosis has a big spleen and needs transfusion. Too old to transplant. Myelofibrosis. This is a Janus kinase myelofibrosis, myeloproliferative disorder. Too old to transplant, and I need to inhibit Janus kinase 2. Janus kinase 2 inhibitor. Janus kinase 2 inhibitor. Ruxolitinib. Ruxolitinib. JAK2 mutation. How do you prevent yourself from jacking off? Ruxolitinib. It inhibits your jack off. JAK2, Janus kinase 2. Janus kinase 2 inhibitor. Now, we have a 55-year-old woman with burning of her hands that are red. Erythro, red. Erythro, red. Myalgia, pain. Algia, pain. Algia, pain. Erythro, red. Myalgia, pain. Painful red hands. Erythromyalgia, and a big high platelet count. Now, symptoms in a platelet count over 1 million. Symptoms in a platelet count over 1 million makes this essential thrombocythemia. This is essentially platelet cancer. Now, the hardest thing about the platelet cancer, essential thrombocythemia or essential thrombocytosis, depending on who's writing it, is that the count has to be really high. Usually at least over 600,000 and usually over 1 million. That's one thing. Because platelet counts are reactive. In other words, platelet counts can go up the same way a white count can go up. White count, sed rate, C-reactive protein, ferritin, and cantrobalamin. A white count is sed rate, C-reactive protein. They're acute phase reactants. So for it to be essential thrombocytosis, it should be over 1 million. Why do you get red hands? Because the platelets are precipitating out in your hands. Wow, clogging things up. Now, sometimes the platelets work too much and you thrombose. Sometimes the platelets don't work enough and you bleed. Sometimes it does both of these things. It does not transform into AML. The platelets sometimes work too much and you clot, and those people get aspirin. They get an antiplatelet drug. That's pretty logical, right? This is too many platelets working too much. It's too many platelets working too much. Let's give you some aspirin to prevent the platelets from working. That's understandable. The other things that can be done is hydroxyurea. Third, what's a drug? Begins with an A that's only for essential thrombocythemia. It's a platelet drug. An antiplatelet drug begins with an A that's only for this. It is anagrelide. Anagrelide. Aspirin and hydroxyurea are first. Aspirin and hydroxyurea are superior to anagrelide. Aspirin if you're not bleeding. Now, anagrelide is an alternative to hydroxyurea that's not as powerful. Which of these converts to acute leukemia the most? Polycythemia vera, very rare transformation to acute leukemia because it's a red cell disorder. Essential thrombocythemia is a platelet problem. See, it's not really all three cell lines. It's not really the same thing as a stem cell disorder, is it? Chronic myelogenous leukemia. Chronic myelogenous leukemia converts into acute myelogenous leukemia at 20% per year. CML converts to AML at 20% a year. Wow. Seems like a lot. That's right. Well, it used to be that CML would kill you by converting to acute leukemia in pretty much everybody by 5 years. But now, imatinib, nilotinib, stop that from happening because when you inhibit the tyrosine kinase, you don't convert to acute leukemia. Boom. Solved. Of a 34-year-old man with 750,000 platelets. It's 750,000 platelets with no erythromyalgia, no clotting, no bleeding. Because it's 750,000 platelets with no clotting and no bleeding, thrombophoresis. Therapeutically, do you know when we do thrombophoresis? Therapeutically, meaning put the blood in a centrifuge, take the blood out, and remove the platelets. You know when we do that therapeutically? You do? Because I don't. I never heard of that. I never thought we could do that. We do thrombophoresis to be a platelet donor. Steroids don't help in essential thrombocythemia. The other thing is, it's not essential thrombocythemia because the platelet count is under 1 million and there's no symptoms. Remember I said that anagrelide stuff? Anagrelide is never first, but it is a one-disease drug. Anagrelide is only for people who have essential thrombocythemia. Now, which of these... Oh, no. Why do we have to learn things like this? I'm not an oncologist. I don't want to know about the CALR test, the calreticulin gene. CML? Oh, shit. I don't know. Yeah, I don't know, because I never heard of it before. Myeloma, calreticulin gene. Well, you know what you do the calreticulin gene for? If you think that you might have essential thrombocytosis, essential thrombocythemia, and the JAK2 mutation is negative, and you're not certain, is this essential thrombocythemia, is it platelet cancer, or is it reactive? Ooh, it's 800,000 platelets, 900,000 platelets. It's not there, but sort of could be, maybe, and the JAK2 mutation is negative. That's when you do that. Man with 850,000 platelets and the JAK2 is negative. What are you going to test for? I don't know. Let me think about it. Oh, hey, ho! That's when it's the answer. That's when it's the answer. Because in this person who's getting up there in platelet count and is borderline in JAK2 negative. Borderline platelets, JAK2 negative. Borderline platelets, JAK2 negative, calreticulin gene. A patient with rashes, eczema, urticaria, and cough and shortness of breath. Oh, there it is. Because prior to this, well, this is the atopic. This is it looks like the allergic part. Oh, eosinophil count 1500. Okay, you're trying to tell me something. Yeah. Is it eosinophil cancer? I didn't know there was such a thing as eosinophil cancer. Lymphocyte cancer is CLL. Neutrophil cancer is CML. Platelet cancer is essential thrombocytosis, thrombocythemia. Red cell cancer is polycythemia vera. Now, I don't have cancer. I don't have any of the reasons to have a high eosinophil count. It's persistent high eosinophil count, but it's with signs of atopic illness. Cosentropin test is normal is telling you that this is not Addison's disease, because Addison's disease is associated with high eosinophils. The same way steroids are anti-inflammatory and steroids get rid of eosinophils, same way steroids get rid of eosinophils, Addison's disease, adrenal insufficiency, is associated with high eosinophil count. So atopic signs, skin problems, eczema, urticaria, skin problems, atopic signs, high eosinophil count without another reason for it. This is hypereosinophilic syndrome. Excess eosinophils. Is it eosinophil cancer? I can't really say that. It's hypereosinophilic syndrome. How do you die? Eosinophils eat my ass. Yeah. You mean you become allergic to your own blood vessels? You start to become hypercoagulable and start to become allergic to your heart? Hypercoagulable and become allergic to my heart? Hypercoagulable and become allergic to my heart? Yeah, man. What is that? This is itchy skin. Next one. Itchy skin lesions, abdominal pain. Next disease. Nausea, vomiting, diarrhea, anaphylaxis sometimes, flushing and hypotension. With that. Urticaria pigmentosa. Diarrhea sign is urtication. In other words, you touch someone, you touch them, and they become urticarial at the height of it. You start tickling and breaking up those mast cells. The mast cells become upset with you because I go, yo, mast cell, gonna punch you in your little granule mast cell, gonna squeeze your little mast cell granules, squeeze them out, and now I get triggered by all sorts of drugs and touch. Sometimes it infiltrates the spleen. It is systemic mastocytosis. Mast cells go into your skin, to your nose, to your liver, to your spleen. Wow, systemic mastocytosis. Welcome to the boards. Would I know that if I wasn't me? But I wasn't always Conrad Fisher. Before I became Conrad Fisher, I wouldn't have known that. Serum tryptase level. Skin and marrow biopsy looking for my mast cells. I wouldn't have known that. If I had my way, I still wouldn't have known it. The treatment, antihistamines, after all. Oh, montelukast, right? So you treat it a bit like asthma. Yeah, you treat it like asthma. Asthma, like leukotriene inhibitors. Montelukast, leukotriene inhibitors don't activate the mast cell. Antihistamine, steroids, and leukotriene inhibitors, just like asthma. Wow. Serum tryptase level. Let's go back to that mastocytosis. Is that a big pain in the ass? Let's do that one again. This is pretty nonspecific. But what is specific? Urticaria pigmentosa, diarrhea sign, urtication at the point of touch. Antihistamines, tryptase levels, steroids. If it gets really bad, really severe, the treatment is chemotherapy. What else gets treated with cladribine? Hairy cell leukemia. So if it's really severe, you treat it as cancer. This is what kills off mast cell cancer. Cladribine hydroxyurea, killing off mast cell cancer, systemic mastocytosis. Which of these causes of leukocytosis has a normal B12 level? Leukocytosis has a normal B12 level. CML? Leukemoid. Polycythemia vera. Leukemoid reactions. Leukemoid reactions because what happens in chronic myelogenous leukemia and polycythemia vera, what happens is that the carrier protein of transcobalamin goes artificially up in the others. In the leukemoid reaction, in other words, a high white count that's not cancer, a high white count that's just leukemia-like. Do you have carcinoma? No, I've got something like carcinoma, carcinoid. Do you have a chancre? I don't have a chancre. I got something that looks like a chancre, chancroid. Are you a human? Are you a human? No, I'm a machine that looks like a human. Humanoid, android. Leukemoid is a high white count that's not cancer. It's up as a reaction. Because it's up as a reaction, the transcobalamin does not go up because it's up as a reaction to another infection or inflammation. Bang!